Morning, ma'am. This is my journal article for Clinical Chemistry 3, the cost-effective management of thyroid nodules and nodular thyroid goiters. Authors Edwin Supit, Alan Paris. Date published May 2002. The prevalence of thyroid nodules in the general population has been estimated to be about 5%. Two procedures, ultrasounds, and autopsy studies have estimated the prevalence to be as high as 50%, especially in the elderly. Most nodules are impalpable, cannot be seen, and benign or mild. Only about 10% of nodules are clinically apparent or clinically visible. The prevalence of thyroid cancer in thyroid nodules is approximately 4 to 6%. Previous studies indicate that there is a 10% to 30% increase. Evaluation of thyroid nodules and nodular thyroid goiter. The clinical assessment of thyroid nodules should include assessment of local symptoms such as hoarseness, symptoms of thyroid dysfunction, medical history of thyroid problems, intervention, and family history of thyroid problems. A sudden increase in size of a previously noted nodule over a period of a day or more indicate hemorrhage. Hemorrhage is an external or internal bleeding in the body, whereas cancerous growth is usually progressive over several weeks to months. Examination. While physical examination is an important part of the overall evaluation, its usefulness in detecting malignancy in the early stages is limited. Palpation detects nodules larger than 1 cm and is neither sensitive for detecting thyroid nodules nor a good method for distinguishing benign from malignant nodules. Physical examination is an initial method used to differentiate benign from malignant. Diagnostic test in the evaluation of thyroid nodules in nodular thyroid goiter. Laboratory test. Thyroid function tests should be obtained, though the results of these are usually normal. The thyroid stimulating hormone level is an important determinant of the next step in the investigation. Thyroid antibody test may be helpful in the evaluation. Radiology. A chest film should be obtained. A comparison of the various imaging tests. Imaging studies are generally expensive and are not usually not useful in differentiating benign from cancerous lesions. Thyroid ultrasonography. High-resolution ultrasonography is the imaging method of choice in the evaluation of thyroid gland morphology. It is a method of choice because it is non-invasive, safe, reliable, portable, relatively inexpensive, and more sensitive than physical examination or other imaging techniques. Thyroid ultrasonography is capable of detecting solid lesions as small as 3 mm in diameter and cystic lesions of approximately 1 mm in diameter and is able to differentiate between solid 70% of nodules, cystic or complex nodules. Needle aspiration. Fine needle aspiration of thyroid nodules has emerged as the default diagnostic test. Fine needle aspiration of thyroid is an accurate method to determine the need for surgery in the most situation. About 85% of thyroid fine needle aspiration procedures result in sufficient cellular material for diagnosis. Of thyroid nodules and nodular thyroid goiter, thyroxine suppression, but there is a disadvantage using thyroxine. It can cause or aggravate osteoporosis, especially in postmenopausal women. In elderly patients, it may precipitate thyrotoxicosis. Cirrhosing agents like ethanol and tetracycline. Some agent has a bad effect like dysphonia, local tissue damage, and fever related to extravasation of these agents. Radioiodine treatment. Iodine can be considered for treatment of hot nodules and toxic multinodular goiters. Surgery. Those patients with lesions confirmed to be malignant should undergo surgery.